I'm Dr. Fred Lublin from the Multiple Sclerosis Center at the Icahn School of Medicine at Mount Sinai in New York. I'm joined by two MS expert colleagues, Dr. Patricia Coyle from Stony Brook University and Dr. Clyde Markowitz from the University of Pennsylvania.
My name is Dr. Pat Coyle. I'm professor of neurology and currently interim chair in the Department of Neurology at the Stony Brook Renaissance School of Medicine, and I direct Stony Brook's MS Comprehensive Care Center.
Hello, I'm Clyde Markowitz, associate professor of neurology at the Perelman School of Medicine at the University of Pennsylvania and director emeritus at the Multiple Sclerosis Center at Penn.
Okay, learning objectives. After engaging in this educational activity, learners will demonstrate improved ability to classify all forms of relapsing MS for early identification and treatment, to describe the need for switching medications using evidence-based approaches for measurement of treatment response, disease worsening, and patient-reported outcomes, compare and contrast the clinical profiles of S1P receptor modulators through research results and patient-reported outcomes, and lastly, to identify approaches to engage patients and caregivers in developing an individualized treatment plan that addresses patients' needs and quality of life factors. So let's take a look at the forms of relapsing MS. So this is Leah, a 34-year-old Latina who's been in good health. She presents to a primary care clinician for blurred vision and eye pain in one eye that began 2 weeks ago. Her only other medical issues are migraine and seasonal allergies. She's had no previous episodes like this, although she has had migraines, and at first she thought she may be having an atypical migraine, but the symptoms lasted much longer than usual. Symptoms are now mostly gone. She decided to keep her appointment and talk with her doctor about it, concerned that it might be serious, and also there's a family history in that her mother has multiple sclerosis.
Based on Leah's presenting symptoms, what type of MS would be suspected?
So, of the disease courses in multiple sclerosis, the latest ones, although one's not all that new, we have radiologic isolated syndrome, or RIS, which is individuals who have an MRI scan done for some reason other than an MS symptom, a bump on the head or bad headache, and the MRI looks like MS. And so work is done on that those people who actually fulfill criteria for MS, at least on the MRI, have a pretty high risk of developing MS. And so this is an ongoing topic that's being addressed and will be addressed in the latest version of the McDonald criteria that will come out next year. And then there's clinically isolated syndrome, or CIS, which is the first attack of inflammatory demyelinating disease, which is consistent with MS. This would be a focal cerebral syndrome, a focal brainstem cerebellar syndrome, a partial myelitis, or an optic neuritis. So the typical CIS presentations are here: unilateral optic neuritis, focal brain syndrome, focal brainstem or cerebellar syndrome, and partial myelopathy. And partial is important. People with complete transverse myelitis, that usually isn't MS. It presents over hours to days. It should last more than 24 hours to count, and it gets better over weeks to months, but it doesn't have to get completely better. And there's a whole host of symptoms that may be involved. I'm not going to detail them all, but in essence, it's the first episode of inflammatory demyelination. But to meet criteria, say McDonald criteria for diagnosing MS, it should be one of the typical syndromes, not an atypical syndrome. And so the diagnosis of MS, the historical diagnosis, has been lesions of the central nervous system disseminated in time and space. Dissemination in time means more than one episode. Dissemination in space means more than one area of the central nervous system, meaning brain, spinal cord, and optic nerves. And as always, there's this caveat that there be no better explanation because there's other pathologic processes that can give you dissemination in time and space. And as you'll see, the concept of time is sort of being challenged. So this is the latest diagnostic algorithm, which is from 2017, the 2017 McDonald criteria. And just giving you a heads up, there will be a 2023/24 criteria, which will change these. But it's not time to discuss that just yet. But the idea is that if you have a clinical isolated syndrome and on the MRI scan, you fulfill criteria for dissemination in space and dissemination in time, you could diagnose MS with that very first episode. if you have a clinically isolated syndrome and the MRI has dissemination space but not dissemination in time, then you can either wait for a new event or look for oligoclonal bands in the spinal fluid. And then if you don't have either, you just have the clinically isolated syndrome, but you don't meet MRI criteria, then you actually need to wait for another event to happen. Now, keep in mind that dissemination in space means one or more lesions in 2 of 4 critical areas, and that's cortical, juxtacortical, periventricular, brainstem cerebellar, and spinal cord. And for dissemination in time on the MRI, on a single MRI, if there are lesions that both enhance and some lesions that don't enhance, that could be a substitute for dissemination in time. Now, of the relapsing forms of MS, you've got relapsing remitting, which is more than one episode. And when those occur, and we saw the time frame, there's a subacute occurrence, it reaches its peak over several days to a week, and then it improves anywhere from 0 to 100%. So on the left-hand side, you see relapses that are improving completely over time. But on the right-hand side, there is incomplete recovery of the relapses, what's called relapse-associated worsening. But in between the attacks, they're not changing, even though they have residual disability. And then we further characterize patients as whether they're active or not active. And by active, we mean have they had a relapse or have they had a new lesion on the MRI scan, and it must be framed in time, for example, 1 year. And so you may see someone and diagnose them as having relapsing remitting MS that was active over the past year because they had had a relapse, or they had had new activity on their MRI scan. But the critical point here about looking for activity is it must be framed in time. For progressive disease, those are in primary progressive or secondary progressive MS, they also could be active or inactive, again, framed in time, but also make the determination of whether over a period of time they're actually progressing or whether they're holding steady. And there's no imaging marker for progression. It's documented clinically only. Now, the 2013 phenotype descriptions accounted for all this. So you could have a clinically isolated syndrome that could be active or not active. And then you have relapse remitting disease. And remember, some clinically active isolated syndromes will then go on to fulfill criteria for multiple sclerosis, and they will be moved to the right here and become relapse remitting disease, which again can be active or not active over a given time frame. And we recommend that it be an assessment at least annually, but a clinician could choose whatever time frame they want. On the progressive forms of MS, there's secondary progressive MS, which is on the left-hand slide, which is a transition from relapsing remitting, where in between attacks or independent of attacks, there's gradual accumulation of impairment or disability. And there still could be superimposed attacks on top of that. But that's mainly progression that's independent of relapse activity. And on the left-hand side, there's primary progressive MS, which is progressive from onset. So instead of starting out with a clinically isolated syndrome, they start out with gradual worsening over time, and they still may have periods where they have acute attacks or acute activity, but most of the progression there is what's called PIRA, or progression independent of relapse activity. And so for progressive disease, you can further characterize it as being active and progressing, active but not progressing, not active but progressing, or stable where they're not active and are not progressing, and all of those are possibilities that may occur. And so here we just see a clinical spectrum of the phenotypes. On the left-hand side, you have relapsing remitting, both without residual, and then as you move a little to the right, you see there's residual, what's called relapse-associated worsening. And then the middle graph is a secondary progressive patient who has both progression independent of relapse activity, but also later on another relapse. And then on the far right is just the course of a primary progressive MS who's not having any relapses whatsoever. So that's all progression independent of relapse activity. And here's a good example of a secondary progressive MS patient. So starting on the left, they've had a relapse in the gray bars, and then they go along, and now in the red, they're starting to worsen gradually. And so they're progressing, but they also have activity. Those little purple arrows are MRI activity going on. So in that case, they're progressing and active. And then when you get to the middle orange, there's been an acute relapse. And then when you get to the green, they're just pure PIRA, progressing without any relapse activity. The blue line is a period of stability. And then when they get to the red again, they're progressing and they've had some MRI activity. It gives you an idea that the spectrum of the disease is quite variable over time. And here's a way of looking at the clinical course ontology, with patients starting with the radiologic isolated syndrome and going on to a clinical isolated syndrome and then typical relapsing remitting, which may or may not go on to secondary progressive MS, because all MS is not progressive. Some people do very well with it, but also some RIS patients, about 10%, go on to primary progressive MS, which then may be purely progressive or may have activity with relapses. But the point there is that the patients that go on to primary progressive kind of ties together primary progressive MS as part of the whole spectrum of all multiple sclerosis.
I'm speaking with Melissa, who's been living with MS for a number of years. So, Melissa, I'm going to turn to when you were first diagnosed with MS, if you tell us how long ago that was, and what were the important things that you wanted to know at the time of your diagnosis, and what was most valuable that you were told, or was there anything missing?
Okay, good morning to you, Dr. Coyle. Yes, I was diagnosed 23, almost 24 years ago. At that point in time, I was just going through a whole bunch of different feelings in my body that I couldn't explain. I couldn't verbally tell a doctor and not feel like I was going crazy. So it was things like spasticity in my legs or what have you. I couldn't exactly explain what it was that I was feeling. All I can say was like it was a rubbery feeling. I wasn't holding my balance correctly or what. All of those important factors that you as a doctor needed to do before I get here that I couldn't verbally speak without feeling like I was going crazy. So when I spoke to people, or when I spoke to my family at least, and I gave them an idea of what it was that I was feeling, they looked at me like I was crazy. So I was, at that point in time, shocked to hear that I was diagnosed with having multiple sclerosis, and that these are the side effects, or the feelings that I was feeling was what I should have been feeling, if that makes sense.
And the sorts of things that I emphasize now that have changed over time are that this is an eminently treatable disease for the vast majority of individuals, that people can expect to live normal lives if they really take care of themselves. I indicate the concept of silent damage to the central nervous system that can occur in MS, so you have to be on your guard for that, and the increasing data that supports how important it is to follow a wellness program and make sure any comorbid conditions are optimally managed, because that helps CNS reserve and helps somebody to age better with MS.
Oh, I agree. I mean, I've learned to eat better. I've learned to take care of my body. I've learned to listen to what it is that it may need, as far as if I'm tired, if I'm exhausted. Understand that these are all part of the things that need to that your body is going through, and you have to have patience in order to have your body work with you, not against you.
And we'll continue with the case study. So this is Leah. She presented with blurred vision and eye pain in her right eye, which began 2 weeks ago, and her symptoms had improved. And we said her mother had MS, and so she was kind of concerned that she may have MS.
Based on Leah's presenting symptoms, what type of MS would be suspected?
So on this question here, based on Leah's presenting symptoms, what type of MS would be suspected? I'm going to call on my colleagues to give their views on this. Let's start with Dr. Coyle.
It sounds like she has a clinically isolated syndrome optic neuritis, so I'd certainly want to confirm that. It sounds like she's not meeting dissemination in space, so she's a CIS high risk for MS if there's no other more likely diagnosis, and she would be offered treatment ultimately.
Yeah, so I agree with Pat. I think one of the interesting parts of this is that when she first presented, she had virtually no other symptomatology other than the vision complaint. And, there was a variety of choices that you could have given with regards to what's the next step. And I think, the most important piece is that she see a doctor, that she see somebody to make sure this is not a primary eye problem, as opposed to a inflammatory process within the optic nerve. So, I think that she did the right thing. She was referred to get an evaluation by a neurologist, and then ultimately had the further testing, which would be most suggestive of a clinically isolated syndrome case. And, based on that, there's a variety of considerations in terms of whether she should have any additional baseline studies, such as looking at her spinal fluid or not, looking at spinal MRI. But from this standpoint, clinically isolated syndrome would be the correct diagnosis.
Okay, so her primary care sent her to a neurologist. His examination history and testing revealed no better explanation than CIS for her eye symptoms, meaning that she had optic neuritis. She had a spinal tap and did not have oligoclonal bands, but her MRI showed lesions in the optic nerve and 2 additional brain lesions. So what conclusion can be drawn based on the results of Leah's assessments? Does she have CIS? Does she have relapse remitting MS? She's not yet a candidate for treatment with disease-modifying therapy, and dissemination in space still needs to be demonstrated to diagnose Leah with relapse-remitting MS. So it said that she had a lesion of the optic nerve and also 2 lesions in the brain, although it didn't specify where. Depending on where those lesions were and whether any enhanced or didn't enhance, she could theoretically make a diagnosis of MS. If she was, for example, had 1 lesion that was juxtacortical, 1 lesion that was periventricular, and 1 enhanced and 1 didn't, then those are all possibilities. Although she could have 2 more non-specific lesions, in which case you have an optic nerve, but you haven't made dissemination in time or space, because she was oligoclonal band negative.
Right. And at the end of the day, are you going to treat this like it's MS, right? Because she may not necessarily meet all the formal criteria in 2018 or 2017, but, maybe in 2023, 2024, that might change. And the reality is, we're clinicians and, she's got a family history of MS. She's got lesions that are consistent. She's got a clinical presentation. I would offer treatment to this individual.
And let's say she has 2 periventricular lesions that really look like MS. She might not meet dissemination in space, but I think that's somebody that I would say is CIS high risk.
Yeah, and I would agree. And that's the type of individual that got entered into the CIS studies that showed that treatment was beneficial.
I'm going to be discussing patient-centered treatment with a focus on the roles of S1P receptor modulators in meeting patient needs. Let's return to Leah, our patient, a 34-year-old Latina who's had a CIS and has lesions on her brain MRI not explained by her underlying migraine. Current recommendations indicate she's a candidate for disease-modifying therapy because she has high risk for a future MS diagnosis based on her suggestive CIS and presence of otherwise unexplained lesions on her brain MRI and no better diagnosis than relapsing MS. So her healthcare provider should be talking about prescribing a DMT after discussing benefits, risks of the various options in the context of her particular clinical situation and treatment preferences.
According to the National Multiple Sclerosis Society, which is a good approach for discussing disease-modifying therapies, DMTs, with Leah.
Well, when we talk about treatment of MS, think about it as a spectrum. It's not just choosing a disease-modifying therapy. It's treating attacks and relapses of the disease in an optimal manner. It's treating symptoms that interfere so dramatically with quality of life and best treating them effectively. It's doing steps to promote CNS reserve to allow this individual with a disease that causes hits to their central nervous system to make their CNS as healthy as possible and to age as well as possible, following a wellness program, right lifestyle choices, identifying and optimally managing any other conditions, any other diseases. Now, when we talk about the DMTs, I personally divide them into 3 groups, which is skipping mitoxantrone, which I don't use anymore. We have the injectable therapies that are not immunosuppressive. They're immunomodulatory. There's no risk of PML, glutaric acetate, and the interferon betas. moderate efficacy. Then we have the orals that are immunosuppressive. They fall into 4 groups, 2 families, the S1P receptor modulators that we'll talk about further, and the fumarates, and then teriflunomide and cladribine. They have efficacy as good or in some cases somewhat better than the needle injectables. And then we have the immunosuppressive high-efficacy monoclonals, the anti-CD20s, natalizumab, and alemtuzumab. I talk about them as 3 different groups. There are pros and cons for each. We have about 10 different mechanisms of actions, but the truth is, for a number of our MS DMTs, we don't know exactly why they work. They all manipulate the immune system, however. And we would just note that the label suggests we not treat CIS patients with alemtuzumab or cladribine. We reserve that for somebody that's had at least 1 or 2 other treatments. And certainly rituximab has been used, but it's not FDA approved for MS. Treatment options, the S1P receptor modulators. Let's focus on them now. The first generation S1P receptor modulator was fingolimod. It was the first approved oral disease-modifying therapy, has a great pediatric trial paradigms, so it's approved for anybody 10 years and older with MS, and it was striking that young pediatric group with a more focal inflammatory phase had great results compared to an IM interferon beta 1A. But fingolimod is a prodrug. It needs to be phosphorylated. It needs to be activated. It penetrates the CNS, and S1P receptors are in the CNS, but it had an unfortunate total failure in its phase 3 primary progressive trial. It didn't work inside the CNS, really supporting a peripheral mechanism of action. And it requires first dose 6-hour monitoring with an EKG at the beginning and end and hourly vital signs. That led to the development of second-generation S1P receptor modulators, and there are 3 of them, siponimod, ozanimod, ponesimod. They are not prodrugs. They have direct bioavailability. All 3 have more limited S1P receptor specificity. That was in the hopes of getting rid of that required first dose observation, which to all intents and purposes they did for the vast majority. And they wanted a shorter half-life to make it more rapidly reversible. That worked in 2, but not in a third out of surprise. Here's when they were approved. Remember, fingolimod in 2010, but then the second generation, 2019, 2020, 2021.
S1P receptor modulators all reduce circulating lymphocyte levels in what range?
The S1P receptors are G protein-coupled lysophospholipid receptors. They're found throughout the body, including the CNS, on all the major players in the CNS. There are 5 distinct receptors, 1 through 5. The S1P receptor 1 is most prominent for fingolimod. It targets about 70% of our lymphocytes, particularly T cells, the naive and central memory T cells, where it doesn't have much of an effect on effector and effector memory T cells. So about 70% of our lymphocytes on fingolimod are sequestered in secondary lymphoid organs. When the fingolimod is phosphorylated and it's activated, it binds to the S1P receptor 1 on these lymphocytes. That's internalized. That lymphocyte can't escape from lymphoid tissue, so it's out of the blood system and can't penetrate into a target organ. That's a strictly peripheral action, and there is some intermediate effect on B cells and natural killer cells as well. Now, there are possible adverse events with the S1P receptor modulators on initiating therapy, bradycardia and AV block. That's the whole reason for the required 6-hour observation with fingolimod. You get a lymphopenia in the blood, can be very low and scary, but it's an artificial lymphopenia. The lymphocytes are still in the body. They're just being held up in the lymphoid tissue. This is immunosuppressive. There have been over 60 PML cases with fingolimod, dozens of cryptococcus infections with fingolimod, so you need to be aware and counsel about those issues. Skin malignancies are something that you want to check for. Rarely hepatotoxicity. Convulsions were found in the pediatric study in 6 of the fingolimod arm and only 1 of the interferon beta arm, although I don't think that's a major problem. There is some pulmonary impact and deterioration in the first 6 months of treatment, and you want to be thinking about macular edema. So here we lay out the primary fingolimod and the three secondary. We see the greater exclusivity in the receptors. So siponimod and ozanimod hit S1P receptors 1 and 5, ponesimod S1P receptor 1 compared to fingolimod. None of these second generation are prodrugs, and you see different doses being used. The half-life is shorter, except for ozanimod, where they were surprised to find two metabolites were actually active, and they had a somewhat longer half-life than the parent fingolimod. But you escape that first dose monitoring for most of the second generation. It's very rare that you need to do it. You dose escalate over a period of time, and that seems to take care of it. And you see lymphocyte reduction ranging from 55% with ozanimod to 70 to 80% with fingolimod and siponimod. And for the most part, the lymphocytes come back faster.
S1P receptor modulators all reduce circulating lymphocyte levels in what range? Identify the true statement regarding clinical trial evidence for the specified S1P receptor modulators.
Well, here we lay out the efficacy of our family of 4 S1P receptor modulators, and you actually see that fingolimod, ozanimod, and ponesimod had phase 3 trials with an active comparator. The only one that didn't was siponimod. And you saw relapse suppression, higher proportions relapse-free, impact on confirmed disability, worsening progression, contrast, new or enlarging T2 lesions, and atrophy. You can't compare between trials, of course, but all the S1P receptors seem to have efficacy here.
Identify the true statement regarding clinical trial evidence for the specified S1P receptor modulators.
So what is that true statement regarding clinical trial evidence for S1 receptor modulators? It's the first one. The annualized relapse rates were significantly lower for fingolimod, ozanimod, and ponesimod versus comparator DMTs. B, C, and D would be wrong. So the pretreatment assessment with the S1P receptor modulators, you want to get an EKG. If there's any hint of cardiac issues, you probably want to get a formal cardiac evaluation. You want to check a CBC, liver panel, IgG to varicella zoster. You want to look to make sure there's no macular edema, particularly if you have a history of uveitis or cataracts. You want to counsel about PML and iris, immune reconstitution, inflammatory syndrome, and the fact that when you stop an S1P receptor, you may rebound, certainly with fingolimod for sure. So you need to be aware of that. You don't use them while pregnant or breastfeeding, and you need to just be aware there can be a negative impact on raising blood pressure. More limited, siponimod needs special genotyping. Very rarely, you may not be able to use it, or you have to use a lower dose. There's a recent label change to ozanimod saying if there's mild to moderate hepatic impairment, it should go to every other day, which is weird because they never studied that, and periodic skin assessments for virtually all of the S1P receptor modulators. Now, have there been studies on the S1P receptor modulators and impact on cognition? Yes. A post hoc analysis of pooled phase 3 data from fingolimod showed a benefit on PASAT compared to placebo. We don't really use the PASAT much anymore. You had in the phase 3 secondary progressive siponimod trial a benefit on SDMT changes versus placebo. And you had Enlighten, a multicenter single-arm study with ozanimod that's really looking at SDMT specifically. It's a 3-year study reporting interim 1-year data. What about patient-reported outcomes? Patient-reported outcomes, or so-called PROs, have not been a major focus in clinical trials, but that's now being strongly encouraged, and they want high-quality MS-specific PROs, ideally. So you can have health-related quality of life PROs. You can have PROs based on severity of symptoms and symptom burden or behaviors. And examples would be in the fingolimod EPOCH study, they actually used a treatment satisfaction PRO in looking at switchers from the needle injectables, interferon betas, GA, to fingolimod with positive satisfaction. And ponesimod in their phase 3 trial actually had a fatigue PRO as a secondary outcome and showed a superior benefit at the end with ponesimod versus the comparator oral teriflunomide. So they are being used. The National MS Society gives us some guidelines about talking to patients about a DMT. Visit in person. Don't start it with a phone. It should be a separate visit to the outpatient department. That's how important a DMT selection is. There are other people that can help provide support. There are some informational resources. It's good to recommend what are the good ones because there can be a lot of crazy stuff on the internet. You really want communication, listening to the patient, shared decision-making, reinforcing and actively participating in that, explaining efficacy and safety, counseling them, explaining how it's going to be monitored, etc. All of this comes into play. So we're going to hear from our patient living with MS now with regard to selecting treatment options. I'd like to focus now on choosing a disease-modifying therapy. I know over the years you've been on several disease-modifying therapies, but if we go back to the very first time as you discussed this with doctors and healthcare professionals, what were the important factors in choosing that initial disease-modifying therapy? How much input did you have as a patient, and did you want that input? And then maybe over the years, as questions came up about changing your disease-modifying therapy, why did those questions come up? And how did you kind of decide to switch to a new agent?
Okay, so first, my children were young. Now I had a full life, a full everyday life, I should say. One that to me needed not to be changed up for their lives, my children's lives. So I chose something that was going to be beneficial for me and something that I can do for me and not interfering with everybody else. So this one specific drug was one that was a self-injection that I could manage myself and then move forward. I did that for many years, and then as progression of the medications came about, I tried a different drug that was going to be a one-time daily a pill form, I guess, that you would inject yourself, or rather you would take and swallow yourself and move forward with that. I moved on to a different drug. I mean, it's 23 years, so progression of medication has come a long way. So you want to try different ones that are going to help you feel better, help you move forward. And right now I'm in a position where it is one that is, it is an infusion that's going on. So it started with a pill, rather an injection to a pill to an infusion. So
I think it's pretty remarkable how much we've expanded and changed and the multiple options that are available. How important, Melissa, is it to you to feel that your healthcare providers are really informed and up to date on MS?
Oh, it's very important because I have all of these questions and all of these experiences that I need to speak with somebody to make sure that I'm on the right path, that what I'm going through, that I'm not crazy, that I should be going through this. And it's very important, and it's soothing to me to know that the medical professions know exactly what it is that is expected and needed. So I appreciate that.
So let's go back to our case study. Leah, a 34-year-old Latina. Current recommendations are that she's a candidate for disease-modifying therapy. It appears that she's a CIS high risk, and we need to prescribe that.
According to the National Multiple Sclerosis Society, which is a good approach for discussing disease-modifying therapies, DMTs, with Leah.
So we have a post-knowledge check. According to the National MS Society, what's a good approach for discussing DMTs with Leah? Clyde, do you want to answer this?
Sure. Well, so, one of the most important pieces to this is really making sure that a patient understands what they're getting involved with. We do not recommend that you do a conversation over the phone or, tell the patient to go out onto some websites to go figure it out on their own. The bottom line is we bring them back for a separate visit to just discuss what the DMTs are, what the side effects might look like, what kind of concerns they may have. And this way, the patient and you have a relationship that is kind of like a shared decision-making. And it's probably one of the most important pieces that we can offer when we're having a discussion about putting patient on a medication for MS in the long term because we need them to adhere to the treatment.
So Leah is finding an oral treatment appealing. She's selecting a second-generation S1P receptor modulator with 2 choices with her health insurance. So we're going to help her pick which one. So we have another exploratory question here. Which of the following is not a key factor for impacting adherence? Cognitive impairment, B, DMT efficacy, C, side effects of the DMT, or D, significant depression? Fred, do you want to comment on this and then just speak about the importance of adherence and compliance?
So adherence is key. If someone's not going to take the medication, it's not going to do them any good. And it's a part of the conversation that Clyde was mentioning at the start to make sure that the patient and the drug chosen fit. Because adherence is not only just taking the medication, but also following the safety guidelines for follow-up studies of blood work and things of that sort. And so I actually disagree with this question because while the answer may be efficacy, I think that the patient has to be on board with the efficacy in addition to all the other factors that are mentioned there. So I think all of the above would be the correct answer here because if the patient is unclear as to what the drug's doing for them, they may not take it. And this is an important point because what we're doing is taking away attacks. So they don't feel anything. It's not like we're taking away pain or relieving headaches or such. What we're doing is limiting disease activity. So if the patient goes a year and says, well, I'm no different than I was at the start of this medication, you're very happy. But they may not understand just what it is. And that's part of the initial explanation of why you're using the disease-modifying therapy.
So I think that really gets to my final slide and final question. What education and counseling should Leah receive before starting her medication? Realistic expectations and benefits, as Fred pointed out, discussion of potential adverse effects, monitoring schedule, and really emphasizing the importance of communication, particularly early on in the treatment when you're going to be seeing the patient most likely more often, perhaps the nurse contacting her, et cetera. Are there any final comments that the panel want to make, Clyde or Fred?
And it's good to have choices.
Absolutely.
Yeah, and it is tremendous in today's world that we have so many choices to be able to tailor individual medications to patients' individual needs and concerns. Okay, so I'm going to cover recognizing the need for therapy adjustments, the importance of disease state monitoring. So we're going to go back to Leah, a 34-year-old Latina with a recent CIS diagnosis who was started on a DMT. And she was started on a second-generation S1P modulator, and the attack that she had initially had resolved completely. So the question that you have to ask is, what are the most important factors when we're making decisions about starting people on therapies and then even monitoring them on therapy? Like, what are some of the factors that we take into consideration? So patients who are at an increased risk for worsening disability might include people who have multiple relapses with a short inter-relapse interval, people who do not completely recover after an attack. Involvement of the motor or cerebellar pathways that lead to disability is a big concern. Older age onset, and a lot of lesions on MRI scan both in the brain and in the spinal cord and brainstem. And we also see in African Americans and to some degree in Latinos as well, a significant risk for a more aggressive course. So we take all these things into consideration when we want to start somebody on therapy and how we monitor them and consider what we're going to do in the future.
Consider another patient with RRMS who has been on interferon beta-1 for 2 years. He is in your office for a scheduled assessment and says he generally feels okay. Under what circumstances would you discuss switching therapy?
So here's a quote from C. Everett Koop that drugs don't work in patients who don't take them. And this really addresses the concern for adherence. We know that patients, no matter what medication you put them on, may not be as diligent about adhering to the protocol for, even simple things like their blood pressure medications or antibiotic courses. But with a disease like MS, this becomes particularly important. And we want to make sure that when we're determining if somebody's having breakthrough disease activity, that they were taking the medication as it was prescribed. Because one of the big concerns we have is that we might say, we need to switch you to a higher efficacy medication that may carry a different safety profile. And in doing so, that may end up being an unnecessary treatment change if we knew that the patient wasn't adhering to the therapy. So it's very important that we make the determination, are they taking the medication? Were there any concerns that we had or they had about them taking the protocol that we prescribed for them? So these are important pieces, because otherwise you may end up with unnecessary treatment changes. So how do we assess people over time? Factors to consider are changes on their physical exam. So on their routine neurologic exam, when they come in for their follow-up visits, to be able to do, a physical neurologic exam, maybe even an EDSS score. We assess whether they've had any clinical relapses, whether there's been any clinical progression. And then we use MRI scan quite frequently these days to make determinations about whether or not a patient is adequately managed, because we know that MRI is more sensitive than the clinical metrics that we currently use. We make determinations on side effects, issues related to fatigue, cognition, depression, etc. And since we have so many options available these days, we're not going to adhere to a medication if they're not tolerating it or there's some progression of disease activity. So these are all important things that we make the determinations, and if it's not working, we make a change in therapy. So when we look at MRI imaging guidelines, when we diagnose somebody initially, we'll use gadolinium on that first MRI scan because gadolinium can give us information about dissemination in time. But on subsequent scans, we may not necessarily need to do gadolinium. So we may do routine follow-up at about 6 months and, maybe 6 to 12 months if diagnostic criteria aren't met. What do we do for patients who are now on therapy? So I think the most important piece is that we get a re-baselining of their MRI scans, which generally most clinicians will say is about 3 to 6 months after starting treatment. And that will be the place as the baseline to go forward and make further recommendations to compare that scan to subsequent scans. And then we'll scan them about every 6 months to a year for at least the first year or two, and then we could probably space that out. There's a slightly different concern for patients who are on natalizumab, particularly if they're JC virus antibody positive, and they're concerned for the risks of PML, in which case we will use the MRI scan more frequently. There's a PML protocol that we use, which is scanning patients about every 3 to 4 months if there's a high concern for PML risk based on duration, previous chemotherapy treatments, as well as their JC virus antibody. And then for progressive patients, we like to have at least a good baseline scan. And if there's an unexpected decline, we'd like to be able to evaluate them. But we don't think that the MRI activity in progressive MS is as active as it is in the relapsing form. So other things that we look for, like I had mentioned, that in some clinics, they'll do a EDSS evaluation. And this is just a brief overview of what the EDSS scale looks like, which is basically it's from 0 to 10, 0 being normal, 10 being death due to MS. And the scale has a number of steps, and the steps from 1 to 4.5 is usually these patients are able to ambulate without any dysfunction, but may have dysfunction in regards to the pyramidal system, cerebellar brainstem, sensory, et cetera. And all these will be added up to give you numeric value. But once you get up to a step of 5, now you're starting to get into the mobility difficulty. And when you get to 6, you might require a unilateral aid of some sort, whether it be a cane. 6.5 may be a walker. And then from there, it becomes worsening gait as time goes. So that scale is a very useful scale. And that's the main one we use in our clinical trials. And there's an evolving world of what we call no evidence of disease activity, or NEDA, which is that there's no evidence of any clinical relapses, no evidence of any worsening on their EDSS score, and then no visible changes on their MRI scan as well. So that's, if they meet that criteria, you'd say that they met NEDA. Now, how do we get to some of these other issues? So, mobile health has been very helpful to try and detect changes in patients, particularly in between their visits. And that's patient-based monitoring. So some self-reported outcome measures, disability assessments. These are all things that patients can be doing at home. They have mobile devices, they have apps on their phone, they can track monitoring and adherence to their therapy, as well as symptom management applications that are available to look for cognitive issues, stress, and diet monitoring. So when I mentioned about NEDA, you can see, looking at this chart, there is not any great drugs that we have that reach anything greater than close to 50% NEDA. With the interferons and some of the other medications, you can see that the NEDA was scored somewhere between 25 and 35%. With the B-cell depleters, we got up into the 40s, but we're still not able to control all disease activity. So we have a lot more room in here to accomplish more effective therapies. So defining treatment failure and breakthrough disease, in 2018, the AN came out with guidelines regarding this. And unfortunately, it is a bit difficult and there's no consensus on this, absolutely. But you should consider a treatment failure when patients experience even one relapse. That may be enough for you to say this medication, may not be the right one for you, particularly, if it's been after the period of time that we felt that drug should be active. And then whether or not 2 or more new lesions on an MRI scan. And, there's some clinicians who feel that even one new lesion on an MRI might be a good reason to make a change, but not definitively. And then increasing disability on neurologic exam over 1 year. So any of these should be a flag in your mind to consider changing therapy and maybe look for a different mechanism of action or something with a more robust efficacy profile. Other reasons to consider switching: adverse events. So if the patient can't tolerate the medication, or maybe now there's an unacceptable change in the risk-benefit ratio, monitoring their laboratory tests with, blood counts, liver function, JC virus antibody, etc. So you have to make determinations about whether or not these are enough of a concern. Is the patient symptomatic from any of these? And then make appropriate adjustments.
Consider another patient with RRMS who has been on interferon beta-1 for 2 years. He is in your office for a scheduled assessment and says he generally feels okay. Under what circumstances would you discuss switching therapy?
So going back to the patient, consider that second patient with relapsing MS who's been on interferon beta-1 for 2 years. He's in your office for a scheduled assessment and says he generally feels okay. Under what circumstances would you discuss switching therapy? A, he has a T2 lesion that has expanded slightly. B, misses about a third of his injections due to dosing schedule. C, ESS score has increased from 1.5 to 2 in the last year. Or D, you really want to follow up on that last relapse he had 18 months ago. And, there is no absolutes in this, but I will say that, if he's missing about a third of his injections due to a dosing schedule, that's an automatic. We need to do something different because we know he's not adhering to the treatment schedule. The other elements here are all kind of soft calls, and these are things that would need to be discussed with the patient specifically. A couple of considerations on the switching arena. Patients should be on therapy for at least 6 months before you consider making a change in therapy. And when you think about whether or not you want to do a washout, there are concerns that we have about doing washout for certain medications. We know that in some cases there could be rebound disease activity, particularly with fingolimod or natalizumab. So we don't really want to do much of a washout at all. But, you have no washout concerns for some of the other injectable therapies or some of the other oral. So you can just go ahead and start the new medication right away. Medication like teriflunomide, you really should consider getting it washed out of the system with a regimen of cholestyramine, which is pretty effective at bringing the blood levels quite down. So why de-escalate? This is an interesting area because we know that as patients age, the disease becomes a little bit more of a progressive neurologic dysfunction and not really seeing as many relapses. And we know that as patients age, they also increase their risk for infections, maybe malignancies. And most of the clinical trials that have been done to date have all enrolled people less than the age of 55. And unfortunately, more than half of our patients are older than 55 these days. So you kind of have to think about which medications to use when, because some of the medications that are more immunosuppressive may be more problematic in patients who are older. And you may want to consider de-escalating somebody who's in their 60s or 70s when you know that these drugs are anti-inflammatory and work best early in the course of the disease, but may not be as effective in the later course. Maybe we can de-escalate to some degree. There's ongoing studies to try and address this issue.
I want to move on now to consider monitoring MS. How often are you being seen currently? You've had MS for a long time. And how often are you being seen now compared to when you started out with MS? I want to ask, have you used telemedicine personally, and what do you think about that? And what do you discuss to try to track the tempo of your MS?
Well, first of all, the telemedicine I have adapted or I have used, and it was great during this whole span of time during, I don't know if I could say this COVID or what have you. You weren't able to get to and from very easily, so it was nice to have that as part of your daily routine. I did in the beginning see the doctor quite often when I was first diagnosed, just trying to figure out what was happening and where we can go and what we can do to help rather slow down the progression of the disease. As of right now, thank gosh, I am seeing you guys every 6 months, and I appreciate that with all of my MRIs and all of my other testings that I need to go through. It is reassuring. It calms down, it lays all of my questions to rest.
That's great. I mean, I think it's very important. So there was a discussion about the monitoring program that you were going to be getting MRI scans at certain times and blood work done at certain times. How important do you think that is to explain to individuals with MS to get their buy-in as they start a new therapy?
It's absolutely important to go through all of the testings that is requested by the doctors, and it helps to lay any kind of questions to rest that you may have, that I may have. The blood work, definitely. MRI scans, absolutely. Sonograms, absolutely. Everything is needed.
Right. Melissa, I really want to thank you for giving us the insight of somebody who lives with MS. I think it's very important for healthcare providers taking care of MS to dialogue and speak to individuals with the disease to understand what's really important to them. So thank you very much.
Thank you, absolutely. It's been real.
So Leah, 4 years later, in a routine assessment 3 years after starting on an S1P receptor modulator, 2 new lesions are identified via the MRI scan. They occurred in the past year and are larger than 3 millimeters. She has no clinical symptoms, no disability progression, and she has adhered well to her DMT prescription. So here's a question. Should Leah's DMT be switched? A, no, just 2 MRI lesions in 4 years indicate she's doing well with this DMT. B, no, she hasn't had a clinical event or relapse. C, yes, the MRI result is just the tip of the iceberg. Or D, after 4 years, the DMT is likely to be less effective.
So I don't think 2 lesions at 4 years is a big deal. I would not switch them. I monitor them more closely, but I don't think that meets a threshold for one would need to switch.
And I agree, the answer has to be nuanced. 2 lesions over a year is disturbing. It would be enough to discuss a switch, but if the patient is otherwise saying they're doing very well committed to the agent, what I might do is do their next surveillance brain MRI sooner at 6 months rather than a year.
I agree with both of you guys. I mean, we see a couple new lesions on MRI scans. We know these drugs are not 100% in their ability to suppress all MRI disease activity. She's done well clinically, hasn't had any relapses, but I agree with Pat. It is something that changes my monitoring for her potentially, where I want to know, is this just a blip on the radar, or is this something that's going to create more problems in a short period of time? Okay, so in shared decision-making, when patients engage in shared decision-making, they learn about their health and understand their health conditions. The most important piece of this is that they get educated. They understand the pros and cons of different treatment options. they can incorporate that into their world, discuss it with their healthcare provider, and be able to kind of collaborate as a decision is made, not just the doctor passing it on to the patient, but that the patient feels that they own the decision as well. And we know that they're more likely to follow up on their adherence as well. So in summary, the diagnosis of MS requires identification of central nervous system lesions, dissemination in time and space with no better explanation. And the types of MS, as we call them these days, is CIS, relapsing MS, secondary progressive MS, and RIS soon to be added to this mix. Clinicians should discuss the DMT characteristics, both dosing, efficacy, and safety with the patients and engage in that shared decision-making in selecting treatment. S1P receptor modulators, fingolimod, ozanimod, ponesimod, and siponimod are very effective oral DMTs, and patients should be monitored for treatment adherence, efficacy, and tolerability. And clinicians should consider switching if patients have insufficient treatment benefit due to poor adherence, poor drug efficacy, or adverse events. So I just want to thank everybody for joining us, and I hope you enjoyed this video.